Now we are going to resume our master class. Now I request Dr. R.N. Sarkar, who is one of our course directors, to introduce today's chairperson, Professor Soumitra Ghosh. Rothin, please.
Thank you, Amulda. Today's topic is a very important topic. It will be delivered none other than our secretary, dynamic secretary Tapas, who is a very erudite speaker. New definition of sepsis is actually based on the pathobiology and the pathophysiology of a host response to infection. Now it is defined as a life-threatening organ failure caused by host inappropriate or dysregulated host response to infection. Today's chairperson is Professor Soumitra Ghosh, who actually needs no introduction. However, it is customary to introduce. Soumitra is now head of the Department of Medicine at Calcutta Medical College, and he is a cardiodiabetologist by his professional, and he's also a good internist. Now, Soumitra, please start the proceeding.
Sir,
thank you very much.
Thank you, sir. It is nice to get the introduction from the former head of the department of this medical college, Kolkata. So now we'll be having a very important session today. And this session is a day-to-day, practice problem of everyday's life of the internists. Every, faculty, every postgraduate face this type of problem every day in their clinical life. So Dr. Tapas Bandyopadhyay is a very well-known academician. He is a faculty of DNB education in Medica Super Specialty Hospital. He is a very senior consultant physician, and he is a well-known person in this professional field, in this organizational field and the academic field as well. He is currently the secretary of API West Bengal branch, and he is a very well-known consultant, well-known across the city and the state, and of this Medica Super Specialty Hospital. He regularly teaches DNB, postgraduates there. So he will be discussing this important topic, which Professor R.N. Sarkar described as a very life-threatening condition of circulatory failure, which causes inadequate oxygenation of the tissues and the cells to meet their metabolic needs, producing a cellular and the tissue hypoxia. So Dr. Tapas Bandyopadhyay will describe this recent classification of shock. And actually, shock has different classification in different textbooks. It often causes confusion, but an approach, systematic approach, how it should, does it predict outcome? Because we always want a good outcome. So for that, we need to understand this mechanism, pathophysiology, and the stages of shock, so that we can reverse the situation. So reversibility assessment, prevention of this multi-organ failure and death is our target, and rapidly identifying the etiology is the most important part of the clinician, so that administering definitive therapy to reverse this condition is important. So Dr. Tapas Bandyopadhyay is a very, eminent person to deal with this condition. He's an intensivist there in Medica Super Specialty Hospital. Dr. Tapas Bandyopadhyay, please start your deliberation on this recent classification of shock. Does it predict the outcome?
Thank you. Thank you.
Those who have the questions, please write in the chat box. We will take up these questions later after the lecture is over.
Right. So, a very good morning and thank you, Professor Soumitra Ghosh, our ICP chairman, Dr. Amol Banerjee, Dr. R.N. Sarkar, and Dr. Shivendu Ghosh, all my seniors. I thank also the API West Bengal branch, its chairman, for giving me this opportunity. So today I will discuss classification of shock. What are the types of...
Is it possible to make it a full screen?
It is not full screen or yet. Just, it was full screen earlier. Today we'll discuss shock, its recent classification, and whether this by classifying shock in different types, the prognosis and the prediction outcome can be made. Now, the most difficult part of this, while we deal with the shock, is that sometimes the shock may not be very obvious in its classification, like whether it is hypotensive, hypovolemic, whether it is septic. So there are at times we may face a type of shock that there is a mixed picture. Like a septic patient or patient suffering from sepsis might have some acute coronary syndrome, and that can produce hypotension and other features of shock. And these two types of shock are admixed. Then the prognosis and the outcome becomes different from a individual type of shock. So we will discuss this shock today with different case presentation. It will be case based. Now I start with a story that we face every day in our day-to-day life, particularly at the present time. We are facing epidemic of a viral disease, that is dengue. And every physician present here, be it postgraduate trainee, be it practicing physician, we are well aware of what the devastating could be dengue and dengue shock. Now, the story of a 49-year-old woman who was admitted to hospital with fever for 5 days. She had no significant medical past history. Her main symptoms...
Slide change karo.
No, I am not actually, this is not in the slide. So I'm telling the story of a person that with fever for 5 days, she had no significant medical past history. Her main symptoms were body ache, headache, loss of appetite, vomiting, and high fever. On day 5 of the illness, a full blood count showed a platelet count of 45,000. There is thrombocytopenia. She was admitted to the ICU. On admission, she was conscious and alert, but was restless and looked very ill. She had a diffuse cutaneous blanching erythema. Her pulse rate there was tachycardia, and there was a blood pressure of 110/70 with a postural drop of 20 millimeter mercury. The sounds were normal. Respiratory rate, there was tachypnea. Her lungs were clear. Abdomen was soft with no free fluid clinically. Epigastric and right hypochondrial tenderness was present. So there lies the importance of getting history and also getting the exact parameters on physical examination to find out the severity of the illness clinically. She was neurologically normal. Her ECG was normal apart from sinus tachycardia. And as there was blood pressure, there was fall in blood pressure, and we are thinking in terms of there was petechiae, etc. Thinking in terms of dengue hemorrhagic fever was the clinical diagnosis at that point of time, and intravenous fluid appropriately was commenced in view of the postural drop in blood pressure. She became hypotensive 4 hours after admission with blood pressure of 70/40 millimeter mercury, and her heart rate was increased to 140 per minute. Repeat ECG showed a diffuse T wave inversion, and urgent echo showed global hypokinesia with ejection fraction of 30% only. So there was severe LV dysfunction. Based on the clinical diagnosis of dengue shock syndrome plus myocarditis, we started inotropes. Repeat platelet count was only 20,000, and the hematocrit rose from 42 to 48%. Fluids were given appropriately with caution, and we replaced plasma with fresh frozen plasma, and platelet transfusion was commenced. She then had coffee ground aspirate through the nasogastric tube and was therefore started on intravenous proton pump inhibitor. She remained in intractable shock with no response to inotropes or intravenous. Steroids were introduced and required ventilation due to worsening pulmonary edema. Her ECG now showed widespread T wave inversion with first degree AV block. She progressively deteriorated, became anuric, and developed acute respiratory distress syndrome. She also developed complete heart block, for which a temporary pacemaker was inserted. Although rate control was achieved, her blood pressure remained low. On maximum inotropes, she was started on intravenous immunoglobulin 0.4 milligram. Her condition continued to deteriorate and blood pressure became unrecordable. Only external cardiac message alone seemed to raise the blood pressure to a recordable level at that point of time. Repeat echo showed further deterioration with a dilated, globally hypokinetic heart, and it appeared that the myocardium was not responding to inotrops at all. She died in asystole shortly afterwards, 15 hours after admission. Investigation results received after the patient showed dengue IgM was positive and all bacterial culture were negative, cortisol was normal. So this is the story of a relatively young patient who was suffering from dengue shock syndrome. Now, I will discuss a bit about what is shock, what is the basic pathophysiology in nutshell, not going to the detail, and then again we'll come back to different types of shock. What is hypotensive? What are the different types of shock, and how we can deal with that type of shock? And by classifying different types of shock, how can we prognosticate? Because as you all know, even 20 years or 30 years back, the death from cardiogenic shock was 80%, almost 70 to 80%. And with the advent of advanced revascularization procedure and advancement of the medical science, now the death rate and fatality has been decreased to a significant amount, a significant proportion, to 20 to 30% only. And sometimes also, all of us know that septic shock is a dangerous condition, and with the advent of antibiotics, newer antibiotic stewardship and different protocols, guideline based, the prognosis has been much better than earlier, and the fatality has been decreased. Now, what is shock? Reduced tissue perfusion leading to tissue hypoxia and dysfunction is called shock. Although circulatory failure manifests as hypotension, but patients in shock can be not that always patient will be hypotensive. Sometimes patient of shock can be hypertensive or can be normotensive. Shock results from a change in one or combination of different factors that are involved in maintaining the blood pressure, that is intravascular volume, myocardial function, systemic vascular resistance, distribution of blood flow, etc. But the key metabolic and cellular changes that lead to shock state are aerobic to anaerobic metabolism. We all know that there is production of lactic acid and it accumulates in the tissue. There is increased permeability of the cell membrane. There is impairment of the sodium potassium ATPase pump and damage to the mitochondria, leading to organ failure and ultimately to death. The mechanism in nutshell is a compensatory mechanism. There is baroreceptor mediated neurohumoral response that leads to increase in the heart rate, increase LV contractility, vasoconstriction, and there are different systems, hormonal systems that are being involved and activated, or RAS activation that leads to sodium and water retention. There is osmosis receptor in the hypothalamus that leads to increased secretion of vasopressin and water retention. And sometimes, and also there is ACTH stimulates that adrenal cortex that leads to glucocorticoid release, and there is water and sodium retention. Now, initial stage of shock, there are different stages, starting from initial, then compensatory stage, then it progresses to progressive stage, and ultimately a stage appears where the shock cannot be reversed, and that is the irreversible stage. Initial stage, there is lactic acid product accumulation. Compensatory stage, there is systemic sympathetic nervous system activation and different effects. Progressive stage, failure of the compensatory mechanism lead to ischemic injuries and metabolic acidosis. And irreversible stage, there is multi-organ failure. And this is the stages of shock already I have mentioned now. Now, there are principally there are four types of shock. One is hypovolemic shock, that is due to reduced effective intravascular volume. There is cardiogenic shock due to the different causes that leads to injury to the myocardium, like acute myocardial infarction, or myocarditis, like dilated cardiomyopathy. But cardiogenic shock can be due to other than myocardial myocardial injury, that is maybe due to sometimes valvular heart disease like acute aortic regurgitation or acute mitral regurgitation. Sometimes we found in case of ischemic injury to the mitral valve, and sometimes it can be due to rapid heart rate that causes decreased diastolic filling, particularly patients who are suffering from cardiac arrhythmia like ventricular arrhythmia, ventricular fibrillation, or rapid atrial fibrillation with rapid atrial ventricular rate. Next is the distributive shock that may be due to massive vasodilatation and impaired blood flow, which we find in case of septic shock, anaphylactic shock, and neurogenic shock. I will discuss each one of them separately soon. But one important thing is that the hypovolemic shock may not be always due to GI blood loss or fluid loss. Sometimes it can be due to third spacing of fluid. That means that there is internal sequestration, like for example, in case of acute pancreatitis, the blood volume is not, the blood goes out of the blood vessel and it accumulates in the interstitial spaces, and sometimes there may be fluid in the pericardium, in the pleural spaces, etc. The last type of shock that we come across in our practice is the obstructive shock, which may be left-sided, the left-sided obstruction or the right-sided obstruction. That means that pulmonary artery sometimes may be the pulmonary artery may be blocked by pulmonary embolism, massive pulmonary embolism, or it could be due to tension pneumothorax, or it could be due to cardiac tamponade. These are examples of obstructive type of shock. So these are the shock types and their prototype example, which I have already mentioned. Now, one needs to understand the hemodynamics while dealing with the shock. As you can easily appreciate that there is decrease in the mean arterial blood pressure in all time, because the definition of shock is the mean arterial pressure less than 65. So be it hypovolemic, be it obstructive, be it cardiogenic, or be it distributive, the mean arterial pressure is will be always low because that is the definition of shock. Now, other parameters that we must know while dealing with the shock is the central venous pressure. In right-sided heart failure or shock due to right-sided heart chamber problems, the central venous pressure will be high. The central venous pressure will be high in cardiogenic and obstructive shock. Obstructive shock means, already I told you that it could be due to tension pneumothorax, it could be due to cardiac tamponade, and the CVP will be low in case of hypovolemic shock or distributive shock, prototype of which is septicemic shock. Then pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure and cardiac index are the two things that you must know. Cardiac index is the cardiac output by the body surface area, and cardiac index will be low in case of shock. And pulmonary capillary wedge pressure will be low in case of hypovolemic shock because there is definitely loss of fluid, and the cardiogenic shock, it will be high, like valvular heart disease, like acute aortic regurgitation or acute aortic stenosis. The pulmonary capillary wedge pressure will be high, and in distributive shock, the pulmonary capillary wedge pressure will be like hypovolemic shock, though there is no hypervolemia, but there is no obstruction in the pulmonary capillary, so there will be less or reduced pulmonary capillary wedge pressure. Another important thing is the systemic vascular resistance. But because that systemic vascular resistance, if it is low or if it is high, it will determine whether it is a warm type of shock or cold type of shock. So that is very important. Systemic vascular resistance will be high in case of cardiogenic shock, and in distributive shock, systemic vascular resistance will be low because there is less peripheral, the artery that supplies the organs are dilated, and there is fall in the systemic vascular resistance. So this slide is very important in view of understanding the different types of shock that we come across, whether it is hypovolemic shock, whether it is obstructive shock, whether it is cardiogenic shock, and what will be the different parameters in distributive shock. Now, just a second. Hey, just a minute. My phone is here. So we start with the case of a 65-year-old female who presented with fever, shortness of breath, and productive cough, and is in a confused state. Why confused state? Because of the hypoperfusion of the brain due to infection. where is the infection? We are coming later. So the patient is suffering from fever, shortness of breath, cough, and in a confused state. There was, on examination, there was tachycardia, there was hypotension. The saturation was borderline, 90-92%. Temperature was high. There was oliguria, chest. There was bilateral crepitations, and the GCS was 10. Other systems was within normal limit. And initial investigation showed leukocytosis with inflammatory markers very high, CRP 170, and there was also renal azotemia. The urea and creatinine was high. Procalcitonin was done in this patient. This is important. Sometimes procalcitonin is not a screening, but sometimes we need to pinpoint the antibiotic choice and the number of antibiotics, whether it is viral or whether it is bacterial. If bacterial, how severe it is. So in those cases, we can actually limit or restrict the use of antibiotics. So procalcitonin in this patient is very high. That indicates that it is not probably a pure viral infection. Probably it is a case of bacterial infection. So EKG showed sinus tachycardia as usual. The arterial blood gas showed lactic acidosis, lactate level was more than 2 with metabolic acidosis. Chest X-ray, right middle and lower zone opacities was there. Blood culture was sent and report was awaited. Sputum was sent, report awaited. Now, what will be the hemodynamics? So probably we cannot get answer because this is a webinar. So I am telling you, this is the diagnosis septic site type of shock secondary to pneumonia and acute kidney injury due to sepsis. So automatically it is a type of distributed shock, and as you can appreciate that mean arterial blood pressure will be low, cardiac output will be high, there is no loss of volume, but the pulmonary capillary wedge pressure will be reduced because there is no obstruction on the left side of the heart, and clinically the periphery will be warm because there is vasodilatation. And JVP, as there is no right-sided preload overload, so the JVP will be reduced. Now the diagnosis, according to the diagnosis, the patient will get antibiotic appropriate fluids, and if the blood pressure is as the blood pressure is very low, if the fluid does not reverse the hypotension, then we add vasopressor, and actually the patient improved on this medication, antibiotic, fluid, and vasopressor, and his kidney function improved, hemodynamically he became stable, and the patient was shifted to work. Specific antibiotics started based on the culture reports later on. So this is the hemodynamics. Now septic shock, as you all know, is defined as a life-threatening organ dysfunction as a result of delayed immune response, and organ dysfunction as an acute change in the SOFA score, sequential organ failure score of 2 or more. I am not going to the detail of the SOFA score. You will get SOFA score in your textbooks. So septic shock is defined, this is the sepsis, and the septic shock is defined as persistent hypotension requiring vasopressor to maintain the blood pressure, mean arterial pressure of 65 or more, and serum lactate level of more than 2, despite adequate volume resuscitation. And then one important thing that we should know that according to the new 2016 guidelines, sepsis 3 eliminates the requirement of SIRS, that is systemic inflammatory response syndrome, to define sepsis, and remove severe sepsis from definition, and is replaced with SOFA score of 2 points or greater secondary to infection. I am not going to the detail. It has been already discussed in a separate class by Dr. Santosen. Now, one important scoring system, that is Q-SOFA, that we use in bedside, though there is no laboratory test, but it makes it a suitable tool for screening possible infection as a source of new sepsis episode in a low resource setting than the standard ICU. Because in our country, there are many ICU that lack advanced laboratory setup, and those cases, by clinically, you can prognosticate. The Q-SOFA includes the following 3 criteria: altered mental status, GCS less than 15, tachypnea more than 22, and the systolic blood pressure less than equal to 100. Now, therapeutic approach of shock, I will discuss a bit. about therapeutic approach in nutshell, the basic thing and what is the main point that you should bear in mind, that appropriate antibiotic should be initiated within the first hour. Every hour delay of starting the appropriate antibiotic empirically actually increase the risk of fatality and the chance of recovery becomes less. So but this should be done only after obtaining relevant samples for culture, avoiding significant delay in antibiotic administration, and proper dose, duration, frequency should be ensured. Adequate fluid resuscitation must be done. The goals of resuscitation in sepsis and septic shock are to restore intravascular volume, increase oxygen delivery to the tissue, and reverse organ dysfunction. And in this regard, one important thing is that crystalloid bolus of 30 ml per kg is recommended within first 3 hours of detecting severe sepsis or septic shock. Fluid resuscitation should be managed as per following protocol. Rescue with initial fluid bolus of 1 to 2 liter required to reverse hypoperfusion and shock. Then you need to optimize during the second phase. The benefits of giving additional fluid to improve cardiac output and tissue perfusion should be weighed against the potential harms. It should be meticulously monitored. Stabilization is the third phase, usually 24 to 48 hours after the onset of septic shock, and an attempt should be made to achieve a net neutral or a slightly negative fluid balance in that particular stage. Then we need to de-escalate the fluid, and this is the fourth phase, where marked by shock resolution and organ recovery, and should trigger aggressive fluid removal strategies like de-escalation of the antibiotic use. Hemodynamic support like inotropes and vasopressor comes after the antibiotic intravenous fluid. If hypotension is refractory to fluid resuscitation, then we should not hesitate to introduce inotropes and vasopressor in the particular patient. We have to correct hypoxemia with different methods. To pinpoint the source of infection, like source control, if there is a urinary catheter, for example, you need to remove the urinary catheter or change the urinary catheter. If there is an abscess, you need to call the surgeon for incision and drainage of the abscess, and you start antibiotic therapy, or you can change the strategy of giving antibiotic therapy from the previous one, or you can de-escalate after the drainage of the abscess. Then monitoring of organ function, hourly urine output is very important, paramount importance. We always take the intake and output chart. We try to calculate the requirement of fluid as per the urine output, and prevention of the multi-organ dysfunction. Ventilatory support with low tidal volume should be kept in mind in patients who are suffering from acute respiratory distress syndrome. So another important thing that you should also know, that what is the ideal fluid in case of sepsis. The best fluid for resuscitation still debated. Use of steroid still debated. But the growing evidence indicates that balanced crystalloids like lactated ringer solution, plasmolite are associated with a lower incidence of renal injury and less need of renal replacement therapy. So isotonic saline is associated with hyperchloremia and metabolic acidosis, and it can reduce renal cortical blood flow. The ideal fluid in sepsis setting is, if available, then ringer solution or plasmolite. Then comes the use of steroids. Corticosteroids, as you all know, that downregulate the maladaptive inflammatory response in sepsis, but the indication and the dose, as found in different literature, is current guideline is the hydrocortisone 200 milligram per day intravenously as a continuous drip, or in 4 divided doses 50 milligram, based on a systematic review showing longer course of low dose steroids is associated with lower mortality rate, but this is again debated. And steroids are stopped when the vasopressors are off. So adrenal insufficiency caused by adrenal suppression can be, we add steroid as adjunctive therapy for patients requiring only higher doses of vasopressor to support that particular phase. And there is no role of prophylactic corticosteroids in septic shock. And these are the poor prognostic markers for factors that comes in septic shock. There are many factors like advanced age, but two important thing that you should keep in mind, that sequential organ failure is one of the most important prognostic marker, poor prognostic marker, and need for vasopressor in the last 24-hour or 36-hour is another important poor prognostic marker. Failure of 2 or more organ systems at the time of sepsis is associated with higher mortality. Then if there is present, other than presence of shock, if there is severe acidosis, pH being below 7.3 and high severity of illness score. So these are the important factors that you should keep in mind. My second case is 59-year-old male with chest pain, shortness of breath, palpitation in the emergency room. The patient was actually hypertensive and his electrocardiogram showed this type of ECG changes. So you can see that there is hyperacute TOF and ST segment elevation in the chest lead starting from V1 to V4, V5, V1, V2, V3, V4. So this is a case of acute myocardial infarction involving the anterior wall, and top T was positive. Chest X-ray showed this type of picture. So you can jolly well understand that there is pulmonary edema. Echocardiography was done. Echocardiography showed moderate LV systolic dysfunction. Ejection fraction was 35%. There was hypokinesia involving the apical, distal, and mid septum, and in that is the hereditary. And the provisional diagnosis was acute coronary syndrome, that is anteroseptal myocardial infarction, and the vital shows hypotension. And for to maintain the oxygen saturation, patient needs 4 liters of oxygen at that point of time. So what will be the hemodynamic parameters? There is a cardiogenic shock secondary to anterior infarction, and you can jolly well understand the cardiac index will be low. There will be B line in the point of focus ultrasound. The pulmonary capillary wedge pressure will be raised. The central venous pressure will be raised. The systemic vascular resistance will be raised. So how do we manage this patient? Fluid resuscitation is required only in patient, not in this patient, but you should keep in mind that whenever you come across a patient with cardiogenic shock, you should always take the right-sided ECG leads in the chest, because to rule out inferior MI or RVMI that may produce hypotension, and that requires fluid resuscitation. Now, this patient, optimal medical therapy was started, including heparin, aspirin, clopidogrel, and other supportive therapy like inotropes. So we need to give inotropes because the blood pressure was very low, mean arterial pressure was low. But the definitive therapy for this patient must be revascularization in the form of either PCI. This is a hereditary coronary artery disease, so urgent primary coronary intervention is the treatment of choice, and it will reverse the hemodynamics found in cardiogenic shock. Now, cardiogenic shock is clinically defined as reduced cardiac output with tissue hypoxia in presence of adequate intravascular volume. In absence of highly experienced care center, the mortality that was earlier, now the mortality has been reduced to 50% or less, but the mortality may be as high as 80 to 90%. Apart from tachycardia, low volume pulse, and distal heart sounds, there are signs of hypotension in the form of low blood pressure that is less than 90 millimeter mercury, or fall in the mean arterial pressure by 30 millimeter mercury. So this is the hemodynamics. Go to the last part, that is the cardiac index is less than 2, hypotension was there, and pulmonary artery occlusion pressure was raised, and pulmonary capillary wedge pressure was also raised. So role of invasive hemodynamic monitoring, we do not do all the time, but sometimes to differentiate between particular type of shock, particularly if a patient is having septic shock and then suffer from cardiogenic cardiac problem, then we need to get the actual picture by pulmonary artery catheterization, or known as Swan-Ganz catheter. And it helps to differentiate different types of shock, because the parameters I am describing here, the hemodynamic parameters, will be different in different types of shock, but sometimes there may be mixed picture, and that requires clinical acumen, clinical judgment, and how you approach each individual type of shock, which one is predominant, which is less predominant. But cardiogenic shock patients with have pulmonary capillary wedge pressure greater than 15 millimeter mercury and cardiac index less than 2.2 liter per minute per square meter. That is the finding that we get in case of cardiogenic shock. High right atrial filling pressure in absence of raised pulmonary capillary wedge pressure correlates with right ventricular myocardial infarction. Now, when we approach a case of managing a case of cardiogenic shock, patient should be admitted in the coronary care unit. Fluid resuscitation should be done. Pharmacological therapy, including judicious use of inotropes, norepinephrine, the dose of 0.2 to 1.5 microgram per kg per minute, intravenous infusion to maintain the blood pressure. Invasive procedure, including placement of central venous catheter for volume replacement, high dose inotrope infusion, and central venous pressure monitoring is required. So you need to put a central venous monitoring catheter as well as the arterial blood pressure monitoring through the artery. And placement of arterial line for invasive blood pressure monitoring is mandatory in this type of patient. Revascularization of culprit vessel by PCI or by CABG is the treatment of choice for cardiogenic shock due to acute myocardial infarction. If a coronary intervention facility is not available, then thrombolysis is the choice. Therapy for cardiogenic shock due to right ventricular MI consists of fluid resuscitation. I have already told you. Sometimes we need to use intra-aortic balloon pump, that is a mechanical device in hemodynamically unstable patients, where you can use it in the emergency room till as a bridge to therapy till the patient is taken to the cath lab for definitive therapy in the form of revascularization by PTCA or by coronary artery bypass grafting. This is the classification, SKY classification, that is the Society for Cardiovascular Angiography and Imaging classification. This is important because by this classification, whether the patient is in class A or class E, the classification classifies A, B, C, D, E, where A is patient who are at risk. This is very important and very useful. This is a patient who is at risk. He is a hemodynamically stable patient who is not experiencing signs and symptoms of cardiogenic shock, but at risk for its development, that is large myocardial infarction or decompensated heart failure. Beginning is the patient that is the pre-shock stage, that is the who has clinical evidence of hemodynamic instability already, including hypotension, tachycardia, or abnormal systemic hemodynamics without hypoperfusion. And patient should be, every clinician should try to understand and detect the shock in at least in this stage, that is at risk or in the beginning. Then there is a classic shock features, that is patient who has clinical evidence of hypoperfusion that initially requires pharmacological or mechanical support, and hypotension is usually present. And the last stage where it is not reversible is the extremist, that is a patient with refractory shock or actually impending circulatory collapse, where you can only give some palliative therapy for the patient. You cannot reverse the shock. Now, cardiogenic shock due to cardiac rupture is a special entity, and it happens usually in the first week of cardiac event, that is acute myocardial infarction, more so in the first 24 hours, and the prognosis and the survival is very poor. Patients rarely survive after cardiac rupture, and cardiac rupture can be diagnosed by electromechanical dissociation with history of angina. Mortality is almost 50%, though it happens in only 1 to 2% or 3% of myocardial infarction. Now I will go on to few important mechanical circulatory device or support devices that we use in case of hemodynamically unstable patients. I will discuss these important mechanical circulatory devices in very brief, only the outline, what is the role of this mechanical circulatory device. And the options include intra-aortic balloon pump, impeller device, and you are well aware during COVID time we have used, and we are still using ECMO support. So what is intra-aortic balloon pump? It is used as a bridge to therapy from emergency room to the cath lab till the patient is having definitive revascularization procedure. It is in the emergency department or post-transfer, the IABP is placed as a bridge, as I mentioned already, and IABP is useful in patient with cardiogenic shock with acute severe MR or ventricular septal rupture or VSD, or when other MCS devices are not available. No other devices are available. Use of IABP reduces systolic LV afterload and augments diastolic coronary perfusion pressure, and thus creates the increasing the cardiac output and improving coronary flow. IABP is not a definitive treatment, as you have already understood, but used only for initial stabilization of the patient. Then comes the ventricular assist device. Use of ventricular LV assist device during reperfusion following coronary occlusion causes the reduction of the LV preload, increased regional myocardial flow, and overall myocardial function. LVAD helps to maintain collateral blood flow by maintaining the cardiac output and reduces reperfusion injury. And the indications are failure of optimal medical therapy. Reason for cardiac shock, cardiogenic shock is reversible as a bridge to therapy, as I've already mentioned, and the patient has reasonable life expectancy. And the most important and the latest is the ECMO, or extracorporeal membrane oxygenation, where the extracorporeal life support, where an external artificial circulator carries venous blood from the patient to a gas exchange device where the blood becomes enriched with oxygen and has carbon dioxide removed. This blood then re-enters the patient's circulation and circuit flow is achieved using a pump, either centrifugal or a roller pump. There can be two types of ECMO. Patients who are hypoxemic despite maximal conventional ventilatory support and who have significant ventilator-induced lung injury or who are in cardiogenic shock may be considered for ECMO support. For respiratory failure, the basic premise is that ECMO will allow the level of ventilator support to be reduced, and which may allow time for recovery from the underlying pathology and recovery from the ventilator-induced lung injury. So if there is severe lung injury, you want to give some time to heal, one should go for ECMO, and that will give you time to think of other modalities of treatment. And there are two types of ECMO. One is veno-venous and another is veno-arterial. And the indications are, ECMO is indicated for potentially reversible, mind it, life-threatening forms of respiratory and or cardiac failure which are unresponsive to conventional therapy. And these are the indications. The respiratory indications in brief are ARDS, aspiration, asthma, post-lung transplant or lung contusion. And the cardiac causes are, cardiac indications are post-cardiac arrest, pulmonary embolus, drug overdose, post-cardiac surgery as a bridge to therapy, cardiogenic shock or post-heart transplant. And these are the contraindications that one should keep in mind, that ECMO should not be used if there is severe irreversible neurological condition, the life expectancy is very less, there is encephalopathy, cirrhosis, history of variceal bleed, moderate to severe chronic lung disease, terminal malignancy, and in case of HIV patients. Related contraindications are very advanced stage, multiple trauma and multi-organ failure. And the absolute contraindication for veno-venous ECMO is severe LV dysfunction, that is ejection fraction less than 20-25%, and cardiac arrest. Absolute contraindication to veno-arterial ECMO is aortic dissection, as you can easily understand, and severe aortic regurgitation. Relative contraindication to veno-arterial is severe peripheral vascular disease, because the vascular access is not there, obviously. And relative contraindication to veno-venous is the high FiO2 IPPV for more than requirement of high FiO2 for more than 1 week. So this is my third case, where a 46-year-old male presented with multiple episodes of loose stool and abdominal pain. That is, there is gastroenteritis causing hypovolemia, and subsequently the patient had hypotension and shock. The vitals were, the blood pressure was low and saturation was 94% in room air, reduced. And there here lies the clinical importance of examining the patient. You will find signs of dehydration in the form of reduced skin turgor, delayed capillary refill, and decreased urinary output. The abdomen is soft, tenderness, there is a tenderness in the epigastrium, Other systemic findings are within normal. The routine blood test, including complete blood count, LFT was normal, creatinine was a bit high, renal azotemia, and the lactate was elevated. There was metabolic acidosis. The electrocardiogram was normal, ruling out any cardiac component so far, and stool examination was non-contributory. And what will be the hemodynamics here? It is a hypovolemic shock, so the system definitely the mean arterial pressure will be low, the pulmonary capillary wedge pressure will be low, the cardiac induced will be reduced, the CVP will be reduced, and as there is vasoconstriction, automatically the extremities will be cold. It is a cold type of shock example. So this is the hemodynamics, and you can easily understand. And as there is vasoconstriction, the systemic vascular resistance is high. And the treatment of choice, you can easily understand that there is fluid loss, so you have to replace fluid. And sometimes where there is internal hemorrhage due to other setting, where there is hypovolemic shock due to blood loss, you need to replace fluid by giving plasma or blood products as essential. This is my fourth case, where a 47-year-old female patient with subacute history of shortness of breath and pleuritic chest pain had past history of left leg venous thrombosis about a year prior to presentation, and you can easily see the ECG. Before that, the blood pressure, there was hypotension, there was tachycardia, there is tachypnea, there is the ECG showed the right ventricle, right bundle branch block. Then there is extreme right axis deviation. There is a S1QT T3 suggestive of pulmonary embolism or pulmonary infarction. There is T-wave inversion in the V1 to V4 and lead 3, and clockwise rotation with persistent S-wave in V6. All features of right ventricular overload. And the CBC LFT KFT was normal. Heart sounds insignificant. D-dimer was markedly elevated, and troponin I was elevated. This happens in case of pulmonary infarction. So this patient undergone echocardiography that suggests grade 1 diastolic dysfunction along with some there is RV volume overload and mild pulmonary hypertension. Doppler ultrasound of the lower limbs showed no obvious intraluminal thrombus, no loss of compressibility of the deep veins of lower limbs, and no calcification in the vessel wall. And CTPA was done in this patient as we suspected pulmonary occlusion, and it showed bilateral pulmonary emboli with more than 75% luminal occlusion of both main bronchial interlobar and segmental pulmonary arteries, confirming the diagnosis of massive pulmonary embolism. And massive pulmonary embolism is defined as acute PE or pulmonary embolism with sustained hypotension that is less than 90 for more than 15 minutes requiring inotropic support. And the mortality is very high, maybe up to 65%. And then what is the low risk pulmonary embolism? Where there is absence of hypotension, RV dysfunction, and myocardial necrosis. And the mortality is very low, that is less than 1%. In between is the submassive pulmonary embolism, that is systolic blood pressure of more than 90 and either RV dysfunction or myocardial necrosis elevated, suggested by elevated troponins. So this one should keep in mind the massive pulmonary embolism that have sustained hypotension that requires inotropic support. Now, this patient was commenced on anticoagulant therapy with intravenous heparin and then subcutaneous enoxaparin subsequently, and inotropic support with dopamine, oxygen therapy. However, she remained hypotensive despite inotropic support. So stabilization was done through ECMO support, and definitive treatment by surgical embolectomy was done. Final diagnosis of this patient, massive pulmonary embolism with obstructive shock, and the hemodynamic parameters, as you can appreciate, is the low mean arterial pressure, low cardiac output, increased systemic vascular resistance, and obviously there will be increased pulmonary capillary wedge pressure. So this is again, I want to highlight that this type of picture you will find in other scenario where the right side of the heart is affected, particularly pneumothorax, tension pneumothorax, and cardiac tamponade, where you will get the CVP and the pulmonary capillary wedge pressure both are high, and the mean arterial pressure will be low, suggestive of obstructive shock. Now, this is the slide that shows that what will be the hemodynamics in already I have shown for different types of shock. In hypovolemic shock for recapitulation, the only thing that is increased is the systemic vascular resistance. Other parameters like pulmonary capillary wedge pressure, cardiac index, pulmonary systolic pressure, it will be low. Distributive shock, there will be the cardiac index will be high as there is no blood or volume loss, but systemic vascular resistance and pulmonary systolic pressure and pulmonary capillary wedge pressure will be low. In cardiogenic shock, the pulmonary capillary wedge pressure may be normal or reduced and cardiac index reduced, but systemic vascular resistance will be increased. And in case of cardiac tamponade, the pulmonary capillary wedge pressure will be obviously raised and cardiac index will be low, systemic vascular resistance will be very high. Other types of shock that we encounter is the neurogenic shock due to spinal cord injury, and that lasts about 3-4 weeks, and there is recovery. And another type of shock that you can come across is the anaphylactic shock that may be due to bee sting or due to ingestion of the peanut, and you need to take appropriate measure, including use of intravenous adrenaline and intravenous fluid. So these are the different types of shock, and different types of shock determine the prognosis. The cardiogenic shock, I have already told you that the mortality is very high in a low resource setting, and you need to undergo primary PCI. In case of hypovolemic shock, the prognosis is not that bad if detected early and adequate replacement fluid is given. In case of distributive shock, particularly today, the first case, the initial case, that dengue, they are very refractory to intravenous fluid and very refractory to inotropes, and we lose sometimes this type of patients. They are very refractory. Neither steroids nor immunoglobulin have any definitive and evidence-based role in the treatment of this type of shock. So with this, I thank you all and invite for your patience and hearing, and I invite questions if any. Thank you so much.
Thank you very much, Dr. Tapas Bandyopadhyay. It was an elaborative, topic, and you have discussed every facets so well. And actually, all the facets have been dealt with the case discussions, particularly, and with the case scenario. This is very important, and actually everybody has been benefited. So few questions have come. Before coming to the questions, I can have some comment also, because of these 4 major categories of shock, what is the usual scenario in a clinical setup? Which one is the commonest? Because once we see the shock, the doctor sometimes, before he calls upon other members of this team to settle the patient, sometimes we are confused what is the basic etiology, because everything in management is etiology directed.
Right.
So I am giving an just incidents. About this. What is the number of shocks in that scenario? If we see 100 cases of shock in clinical scenario, we see 62% septic shock. So it is actually the commonest one. It is a distributive kind of shock. Another 16% we see the cardiogenic shock. Another 16% is hypovolemic shock. Another 4% is other kinds of distributive shock like anaphylactic shock, neurogenic shock. Only 2% can be of this, obstructive shock. So if we can remember, this is the usual, this is a big study and the incidences have been taken from that. So that will actually guide us that which has to be taken into account. And as Dr. Tapas Bandyopadhyay in every case scenario regarding the hemodynamic assessment, he has given focus to the clinical points. What should be the JVP? In case of hypovolemic shock, on the contrary, in case of cardiogenic shock, JVP will have a definite change. And every distributive shock will not have a pronounced cardiogenic shock unless it is a mixed etiology. And this is also important that Dr. Tapas Bandyopadhyay has discussed, that sometimes these etiologies can be mixed because patient may be having sepsis, at the same time maybe having renal failure, maybe having cardiogenic shock. So those kinds of patients have to be dealt, particularly well, so that every etiology is actually, given adequate care to restore, to prevent this death and the multiple organ dysfunction. So we have taken few questions, and
One
in
thing,
the chat.
one thing I would like to add in this perspective is that diagnosis should always be made in the background of the shock that is happening, because say a patient is suffering from massive road accident, so obviously it will be hemorrhagic shock or hypovolemic shock, and the results are very rewarding if you can definitely you can block the artery that is causing hemorrhage, or and replace the fluid. That is one important issue. Second issue is septic shock. The diagnosis should be done at least within hours, so that antibiotic can be started within the first hour or the second hour, because as I've already mentioned that the every hour delay will cause increase the mortality rate and fatality rate of septic shock patients. So hypovolemic shock is definitely one of the reward shock that if we can diagnose at first go, and if we can take some intervention, then the results are very rewarding.
I fully agree that hypovolemic shock and other kinds of distributive shock, they are often reversed so well. And if we cannot reverse these cases, like cardiogenic shock, we sometimes fail to reverse the situation, because if we give fluid, that can cause further challenge. So we before coming to this discussion further, we'll take up the questions raised by the participants. We have 3 questions right now. We have few comments. We are coming to the comments later. Dr. R. Bhattacharya has raised the question, Ringer lactate solution. It has been selected as this number 1, fluid therapy in the hypovolemic state or the redistributive shock, and lactated Ringer, because in case of tissue hypoxia, this lactate level is already raised. So whether this lactated Ringer lactate, which contains 28 milliequivalent per liter of this, lactated RS, whether that can increase lactic acid further, so whether it is going to harm more. Can it be given in severe septic shock, because there is acidosis and at the same time serum lactate level is more? Whether this lactate level is a surrogate marker of severity of sepsis, or in itself the lactate is the major offending challenge. So Dr. Tapas Bandyopadhyay, please respond, and
Yes.
I will also give some comments later.
No, we need to actually assess the lactate level in case of septic shock particularly, and in those cases ABG should be done every sometimes you do it morning and evening. So if the lactate is very high, we should be very much careful in choosing the Ringer lactated solution.
So I have one comment, because lactate is the surrogate marker of the tissue hypoxia. So increasing the lactate level by this lactated Ringer solution does not increase the risk.
Yes.
Because on the other hand, it is a very balanced fluid, and if we can redistributive shock state, if we give adequate fluid, which is Dr. Tapas Bhattacharya has given, at least it should be 30 ml per kg of body weight. So it should be enormous in volume. So that lactate is easily metabolized in the liver, and it is converted in the kidneys as well. So that does not increase the risk, and several studies have been taken up, whether on the Paripashu it has normal saline versus lactated Ringer. And several studies have confirmed that lactated Ringer solution, so adding lactate in that situation does not alter the situation, because lactate is the product of this anaerobic metabolism in that situation. That in itself is not the harmful thing. That is a surrogate marker of the tissue hypoxia. So lactated Ringer solution is the fluid of choice that can be given, and on the other hand, normal saline can also be chosen. Dr. Saurabh Pal has raised the question that in case of obstructive shock like pulmonary thromboembolism, when to do catheter-directed thrombolysis or pharmacological thrombolysis like this thrombolytic therapy in massive PTE. Dr. Tapas Bandyopadhyay has given a fantastic definition what is actually called a massive PTE by the hemodynamic alteration and the time duration of that, I mean, hypotension in the clinical scenario. So, Dr. Tapas Bandyopadhyay, will you please give catheter directed in every scenario, because not in every scenario we will be getting this facility of catheter directed thrombolysis in an acute setup.
Yes, in acute setup, actually, we definitely thrombolysis is an option, but if the patient is going down and the hemodynamics are very unstable, we need to transfer the patient for catheter-directed clot suction or surgical management of the.
If the setup permits and the clinical scenario of the patient has improved, go for this, I mean, intervention.
Yes.
Dr. Saurabh Patro has raised a very important question. Very important questions, because 62% of every shock is the septic shock. Empiric antibiotic selection in septic shock, whether we can select, because it is an acute setup, because the culture report will take some more time. What?
Yes.
How to select that empiric antibiotics?
Yes. Actually, you need to consider the infective organism that in a part of a particular region or particular hospital. See, for example, in our hospital, there are main 4 types of organism or 5 types of organism we do come across, and the most notorious is the Acinetobacter. Even it varies from ward to ward. In a particular setting, ICU setting, maybe Acinetobacter is the predominant organism, and we should take into account that factor. Say 80% are resistant or 90% are resistant to the multi-drug resistant organism, and only sensitive antibiotic is colistin and polymyxin B. And other types of organism that we do come across is Staphylococcus, Pseudomonas, E. coli, and Klebsiella. Klebsiella is again very notorious. Pseudomonas is also, and one should take into account the drug susceptibility in that particular hospital or ICU setting before giving empirical antibiotic therapy. Accordingly, we choose antibiotic as per the, suppose a patient is Pseudomonas, so we have to think of that particular antibiotic. Or suppose a patient is having resistant to say piperacillin tazobactam and sensitive to meropenem, usual scenario what I am telling, and you can assess from the data you are keeping with you in that particular hospital. So we choose accordingly the antibiotic from even from ward to ward or in that particular hospital. So that
thank you very much for it is a very important comment, but at the same time I want to add one more line, that many of the cases comes directly to the hospital. It is not nosocomial. So this hospital antibiogram is important when it is nosocomial only. This patient is set up in the ICU setup, patient has gone into shock, getting treatment for more than 40 hours, 8 hours in the hospital. That is important. But those patients who are coming, we'll have to try to localize. Suppose if the patient is suffering from UTI, we'll definitely go for this gram-negative coverage more. If the patient has a cellulitis or some other kinds of, I mean, hand infection, pyomyositis, we'll definitely go for the staphylococcus. I mean, empiric therapy should be, clinical examination should be clearly given by the bedside. If we can focus, what should be the case scenario which Dr. Tapas Bandyopadhyay utilized at the beginning? It was a pneumonia, and then a patient went into shock. So this empiric antibiotic selection will also be directed by this organ involved, which is predominantly causing this septic foci and this septic shock. Another question has come is, what should be the strategy for fluid management in CKD patients with septic shock? Very important question, because fluid balance is important. That's Dr. Banerjee, please.
Yes, that should be guided by the different hemodynamic parameters and the urine output definitely. As the urine output is getting low, if the patient is very much oliguric, you have to restrict the fluid. If urine output improves, then again you have to titrate the fluid, and accordingly you can assess how much fluid you can give in 24 hours.
So intravascular volume status is very important, and in this perspective, in this perspective, there is question, one comment is there in the chat box. What is the role of this IVC assessment, this imaging of this IVC? How to, whether this that can guide this fluid management?
Yes, so this is very important. One of the day-to-day we do it regularly, particularly in our ICU setup, if the patient is having hypovolemia and we suspect that they are some. This is because mainly done to assess the IVC assessment mainly done in patient who are having not only hypovolemic but sometimes the patient may be fluid overloaded and externally we cannot assess. So the IVC diameter as well as the compressibility, how much compressible the IVC is. Suppose the IVC is 2 centimeter or more and the IVC is full, then one must take into account that the fluid is there. You need to remove fluid, but if the patient is dehydrated, it will be reflected in the IVC. The IVC will be collapsed. So point of care ultrasound is one of the latest parameter that one should take into account. One should be expertise, not expertise, but one should be very much aware and must know how to assess IVC.
So,
and from yes.
What is your personal experience in your setup, whether it is equivalent to this CVP monitoring? Because CVP monitoring is an intensive.
It is a handy tool definitely, but CVP monitoring definitely is.
This is a non-invasive procedure, which can guide you to other fluid therapy. Is it equivalent to the CVP monitoring, or CVP monitoring should be preferred in?
Definitely. Central venous line, the hemodynamics are more accurate, but where it is not that much in low resource setting, you can go for IVC monitoring because only an ultrasound probe is required. You can assess the hydration status or dehydration status by IVC. It is not equivalent to definitely, or it is less inferior to CVP monitoring.
So in such challenging situations, we should take these options from this CVP monitoring and this at least by this USG monitoring of this IVC regarding this fluid, how much fluid is optimum. So another question has come, what should be the fluid of choice in shock with CLD patients? Any difference? Or in chronic liver disease?
Chronic liver disease patient with...
what should be the fluid of choice? An anonymous attendee has placed the questions.
No, the fluid, in general, the guideline says that lactated ringer is safe in case of, and followed by if it is not available or if there is any allergy to the particular fluid, then we can go for normal saline.
So what should be the capillary refill time in distributive shock? Question raised by a medical college PGT, Sheikh Arif Ahmed. So capillary refill time is a surrogate marker of this sluggishness of the peripheral circulation. It is a non-specific marker. It is normally 2 seconds. Up to 4 seconds, we actually do not take much of action. We call it an increased capillary refill time when it is more than 4 seconds. In dengue and other things, when the patients actually have hypotension, we often see it is more than 6 seconds even. So that is an important bedside test to assess the sluggishness of this capillary, flow, peripheral circulation. This is an important marker. So what will be the capillary refill time in distributive shock? Whether that is an important and reliable marker, because we need more precision. This is not a precise marker. So whether we should depend on this non-specific and marker like this capillary refill time in monitoring or planning our fluid therapy and other protocol to salvage the patient out of shock.
No, it is actually a supplement, not that you can assess solely depend on the capillary refill time, along with other parameters like blood pressure, like patient hydration status, like the setting that is causing the hemodynamic problem. You can also add capillary refill time as one of the marker that can help you to support that, yes, there could be increase or decrease capillary refill time to determine the severity. Not that you can solely depend
but that should be clearly monitored by the bedside, because that is instantly, I mean, decided upon.
Yes,
And
like
it is a
IVC
clinical tool. Yes,
yes.
yes.
Like
And
IVC.
it can be done even faster by the clinical tool by just touching the patient.
Right.
So many in the chat box, different questions have been come, and there is a monopoly of this chat box chatting by Dr. Shivendu Ghosh. The status of the quick SOFA score now, because if often we actually do not come into the SOFA score so fast in this ICU setup or in the ordinary medical, I mean, world and in general world. So it is difficult to come to this SOFA score so fast. So this whether quick SOFA score or Q SOFA score may be helpful in such situation.
No,
Status of this Q SOFA.
Definitely, there is no laboratory marker there in the Q SOFA score. Only depends on 3 important clinical marker. It guides you in a low resource setting, but definitely SOFA score is much better. And if the score is 2 or more, the prognosis is getting.
But Q SOFA score can be attained by within 1 minute.
That is the important.
In a shock stage,
yes,
it is very important to assess the patient. The 1 minute assessment
right.
may save the patient, because if your assessment takes more than 2 hours, we often lose the patient.
Yes, it saves time and it guides you that you are in the right direction.
So we'll try to get the SOFA score
right.
to I mean organ assessment, because 6 major organs are assessed: brain, lung, heart, liver, kidney, and these platelets. I mean these hemodynamics, other changes. So these are the major organ which are assessed by the SOFA score. But Q SOFA is very important because within seconds, within 60 seconds, 60-second assessment by the bedside. It is a classical teaching of our teachers, and we often also try to teach by the bedside that when the patient of shock comes to you, do an 1 minute assessment and plan your therapy. Ionotrope of choice in myocardial infarction patients with shock. What should be the, whether we should start with dopamine, dobutamine, NORAD, or add, what should we?
Septic shock
in myocardial infarction. Question is,
yes.
It is a cardiogenic shock.
Yes, dobutamine will be that.
Dobutamine is this this chronotropic effect is better. Inotropic effect is good or not good?
Inotropic effect is good, but not that of compared to noradrenaline.
Professor Dr. Amol Kumar Banerjee, can you please give a comment on this myocardial infarction shock inotrope of choice?
I think Tapas has explained everything.
Yes, sir. So, sir, we have discussed this Ringal lactate solution in sepsis already done. Prophylactic adrenaline, anaphylactic shock.
Actually, what I tell, what you are also discussing, we tell the NORAD is used up to when blood pressure, you raise the blood pressure, systolic blood pressure up to 80 or 85 millimeter of mercury with NORAD.
Yes.
Then, after the patient achieves the blood pressure level of 80 to 85 millimeter of mercury, then you can start, as Tapas has suggested, dobutamine. So when the pressure is very low, dobutamine won't act.
NORAD.
The drug of choice is NORAD. Okay.
Sir, thank you, sir. So Ringal lactate solution, we have discussed about it. Prophylactic adrenaline in anaphylactic shock. Why it is prophylactic? Patient has already presented with anaphylactic shock. The question is dubious.
Yes, only the patient is having features of anaphylactic shock, then only you can give it. I don't know.
No, already the question is actually dubious. The prophylactic adrenaline in anaphylactic shock. So why it is prophylactic? Because already anaphylactic shock is there.
No. Can I make a comment over here?
Sure.
What happens particularly, there are plenty of literature throughout the globe, particularly good literature from Sri Lanka. When they are putting the patient particularly on ASB, now this is a important practice that they give half dose of adrenaline.
No, that is not actually beneficial. That is not good.
No. That is the reason I told this question. Not that those you are contemplating that anaphylactic shock may happen. So can we give? That is my question. It is not the already.
So it is a specific situation regarding this anti-snake venin. Giving before that prophylactic adrenaline, whether it should be given or not. Lot of studies have been taken up. Snake venom, anti-snake venin do not cause anaphylactic reaction. It causes anaphylactoid reaction. It is not IgE mediated. It is IgA mediated. That does not cause a life-threatening condition. It takes 20 minutes to develop. It does not usually develop within 1 minute or so, as like this anaphylactic reaction. So prophylactic adrenaline is not to be given, and several countries like Sri Lanka is giving, Tamil Nadu gives. They are their protocol. Even West Bengal protocol has given a half-minded, half effort, this half dose of adrenaline to be given. Actually, these are the tentative ones that actually shows the confidence lack of this physician side. That is not required, because that can be well taken care of if this identification of the symptoms, when there is shaking chills, when there is urticarial rashes or something like that, fever, we can take up this case, we can stop this ASB, and we can give this adrenaline. That is, prophylactic is not required when this situation comes.
That is my question for this.
Sir, it is not to be given, sir. Okay, sir. Thank you.
Yeah, that's a separate issue.
Yes, yes. So crystalloid versus colloid. So what should be the given? Dr. Tapas Bandyopadhyay, would you like the crystalloids here? Because in septic shock, what should be your choice? Colloids or crystalloids? What fluids you have already discussed? Or mostly the crystalloids?
Yes, reactivated ringer or plasmaloids.
Yes. And even normal saline could be given.
Yes.
Shock in GI bleeding due to variceal bleeding, NORAD versus vasopressin. It is mostly vasopressin, because it is the dictum. Tropical versus non-tropical infection in septic shock. Any idea? I will actually rather request Dr. Shivendu Ghosh to please comment on this.
What is the question?
No, I think this is something very, very, very important. Particularly, think of patient of scrub typhus. Think of patients of falciparum malaria. We have got plenty of medicine which can reverse the whole process within few hours, rather than of septic shock, where it requires time, and mortality rate between Western and our country probably does not differ. But tropical infection, scrub typhus, falciparum malaria, and leptospira, all we can treat the patient infection in a better way, and we can get back the prognosis in a better way. That's
I fully agree that if the identification of the cause like dengue, malaria, scrub typhus, and appropriate treatment can restore the situation so fast. So one comment can be done here. If we use different kinds of, these pressure agents. So use of pressure agents is a bad prognostic markers, as in the SOFA score also it is said that whether you are using one pressure agent or combination of pressure agents, that is a bad prognostic marker. And actually use of these pressure agents usually do not change the mortality so well. So that can restore the situation to some extent. This BP can be increased, but this mortality benefit is not too much with this pressure agent.
And longer the use of cyanotropes or vasopressor, worse is the prognosis.
Yes, that is a very important point. Yes. And that is actually in the SOFA score also, in the regarding this cardiovascular or the circulatory assessment, in the in the scoring of 2, 3, or 4, you will always see that this pressure agent addition is an important marker. So I think there is no further question in the chat box or in the questions also.
The bottom line is that there are two important points that PGT should take.
Now, one question is still there.
Okay.
When to add IV steroid in shock? Sir, kindly elaborate further. Dr. Tapas Bandyopadhyay has elaborated in septic shock. When other kinds of shock, in septic shock, Dr. Tapas Bandyopadhyay has already said that actually gives a benefit to some extent, and that can
there are a lot of controversy. Particularly, I saw one patient that was treated outside of our state, and the patient was not having any sort of macrophage activation or HLA. Neither the patient has any features of septic shock, but the patient was given some of steroids. I don't know, but other than septic shock, there is no role of steroids in any type of shock. That is
in anaphylactic shock also we can use it.
Definitely, yes. And
in septic shock,
yes.
If we use steroid, that should be used for only 72 hours, and it should be dividedly used either in the infusion or 50 milligram QDS dose. In the initial 72 hours, it should not be used for long, according to the surviving sepsis guidelines.
Right.
I think I've got a comment over there, Tapas.
Sir.
Particularly yesterday, I've got a patient, hospital I got over phone, and the patient is a driver and having features of meningococcemia. And I think this is situation where steroid has got a problem.
Yes.
Meningococcemia or meningeal infection, early steroid therapy have some better prognostic marker. That is one of the issues.
Yes.
Every student must see the skin properly in a patient having meningococcemia or even pneumococcemia, where there is adrenal involvement is also there.
Right.
Another important issue. What I have,
Yes.
Yeah, tell me.
That is the situation. We need to take
Situation.
Okay.
So the answer is over, or can I go for the next question?
Yes.
No, I've already I've told you. I have the comment only. I have not a question.
Right. Thank you for the comment. And one question is there: in variceal bleed related shock, if one uses vasopressin, simultaneously can he use terlipressin?
Additionally,
so correction of the shock and the stoppage of bleeding.
Yes.
Terlipressin is used for this stoppage of bleeding, and vasopressin is to increase this BP level.
Right.
So in that hypovolemic shock, if this vasopressin is being used, simultaneously whether terlipressin can be used there or not.
Actually, one type of agent we do use, but if the patient is not responding, then one can go on adding the second agent to look for response. That is the...
Okay. So thank you very much. In such situation, if the patient is very in a shock stage requiring vasopressor agents, maybe the bleeding is profuse. In such situation, if the patient this setup permits, then we can go for this. I mean, directly this variceal other interventional procedures. That is much definitive. So I think there is no further question and no comment box in the chat box also. So I will go to the seniors, the course directors, Professor Rothin Sarkar sir and Professor Amal Banerjee sir, to give the final comments to wrap up and to give their final opinion, sir.
Okay, thank you, Soumitra and Tapas, for your very lively discussion and informative discussion.
Thank you, sir.
Now I request Dr. Sotto Ganguly, who is one of our course directors, to give the vote of thanks.
I must say that it is one of the marvelous presentation I ever seen in my life, and it also teaches us that now the classes, master classes, should be given to rather young people who are actually working on this. And I think this should be divided into two parts: septic shock and non-septic shock, as there are many issues. I first congratulate Tapas Banerjee for his beautiful appearance and speech, also Soumitra for conducting it, and also other present. And I think that this morning session is becoming highly academic, and our youngster must open their window in an open mind to gain some knowledge from it. Now, thank you all. Now over to Professor Amal Banerjee for his final comment.
Thank you, Sotto Ganguly. Our next masterclass would be on